Welcome to the Heidelberg Engineering Academy. I'm Jocelyn Gageway, and I'll be moderating today's session. Please note that your phone lines have been muted to prevent any feedback. If you have questions during the presentation, please use the embedded chat feature at any point. Topical questions will be addressed if there is time at the end. Otherwise, they will be addressed by chat or email. With that, I'd like to begin today's presentation, Ultra-Widefield Fluorescein Angiography in the Management of Diabetic Retinopathy, presented by Dr. Robert A. Sisk.
I'm Dr. Robert Sisk from the Cincinnati Eye Institute and the University of Cincinnati. Thank you for joining me in this webinar discussion on the use of ultra-widefield fluorescein angiography in the management of diabetic retinopathy. I have no disclosures other than that I am receiving the standard Heidelberg Engineering webinar speaker fee for preparation and presentation of this course. We'll first be conceptually discussing diabetic retinopathy as a disease and societal burden. Then compare ultra-widefield imaging to traditional fundus case camera-based fluorescein angiography. And finally discuss practical applications of ultra-widefield fluorescein angiography in diabetic retinopathy. Diabetic retinopathy remains the leading cause of preventable permanent blindness in the United States despite technological advances in screening and treatment and improved access to care. It represents a huge financial burden, not just in direct costs of care, but also from lost economic productivity of patients and caregivers. CMS has recognized this problem and placed increased scrutiny on physicians to demonstrate our containment efforts of this disease. Telemedicine programs have been initially successful in stretching limited physician resources to underserved populations. Diabetic retinopathy follows a predictable pattern of centripetal progression that underscores the importance of peripheral retinal examination. Fluorescein angiography reveals more retinal vascular remodeling than by inspection with indirect ophthalmoscopy or fundus photography. Since we do not directly manage the underlying diabetes as ophthalmologists, our goals are to prevent vision loss with treatment when certain thresholds of disease are met, and provide feedback to the primary care physician or endocrinologist. Ultra-widefield fluorescein angiography may help detect treatment-worthy disease earlier than conventional methods and thereby prevent vision loss in our patients. So why do we need ultra-widefield imaging? What's wrong with the way that we've been doing things for the last 20 years? The gold standard for evaluating and staging diabetic retinopathy for clinical studies has been the ETDRS standard 7 fields. While reasonably effective at evaluating macular disease among diabetics in the pre-OCT era, the entire composite covers only a fraction of the fundus and misses the majority of the peripheral retina, which is where diabetic retinopathy is. In contrast, ultra-widefield fluorescein angiography easily encompasses all the composite images of the traditional 7 fields evaluation in a single image, while having the distinct advantages of fluorescein angiography over fundus photography. Fluorescein angiography better reveals capillary dropout, including macular ischemia, highlights areas of prior laser application as window defects, reveals retinal neovascularization with early leakage, and provides a qualitative assessment of the vascular endothelial growth factor, or VEGF, burden in a diabetic eye. Even compared to the 55-degree wide-field angiography images previously obtainable with the stock Heidelberg Spectralis HRA OCT, the Sterini ultra-widefield lens covers around 4 times the retinal area, as you can see in this picture. While individual high-resolution images can help discern specific causes of observed hypo or hyperfluorescence and correlate with OCT, a broader view can help quickly answer whether a patient has active proliferative diabetic retinopathy or treatment-worthy disease. In the real world, we don't always have the luxury of time in acquiring painstaking study-quality photography and constructing montages. These images demonstrate the real-world imperfections of those attempts in my own practice. In practical terms, the ultra-widefield images save time and improve patient care. The photographer can shoot fewer images. The peripheral fundus is captured even with poor patient cooperation. If even further peripheral evaluation is desired, the patient doesn't have to follow a target as far as with the traditional lenses. The resulting images are all in the same phase of the angiogram, and no montage is required, and therefore no montage artifacts are generated. Now we'll look into the results of recent clinical studies using ultra-widefield fluorescein angiography evaluating diabetic retinopathy. Once again, we return to the fundamental question: does the patient have disease that is treatment worthy? It's important to note that there were significant grading disparities between standard 7-fields photography and ultra-widefield color photography. Ultra-widefield images revealed more severe disease in 10% of patients and captured 1/3 of significant lesions outside the standard 7-fields photograph. That same group also noted, as one might expect, that subtle but important diabetic retinopathy findings, including those indicative of treatment-worthy disease, could be missed by color photography if resolution was inadequate. As we discussed earlier, fluorescein angiography has the advantage of highlighting those areas for identification even when resolution is reduced. Proliferative diabetic retinopathy evolves when a threshold of retinal capillary loss is reached and VEGF levels are elevated enough to produce fibrovascular proliferation. VEGF is a potent vasopermeability factor demonstrated to modulate diabetic macular edema. VEGF may also act in a positive feedback loop to further increase capillary dropout. Ultra-widefield angiography can allow earlier identification of severe capillary dropout even in fundoscopically bland retinas to guide treatment of ischemic retinal disease. Lastly, let's see how ultra-widefield fluorescein angiography can influence our surgical plan. Historically, diabetic retinopathy treatments were driven by findings on fundoscopy and visual acuities. Treatments were destructive by nature and carried a higher risk of worsening visual acuity or visual field, often in a delayed fashion from enlargement of chorioretinal atrophy induced by laser. As you can see in this image, there is extensive laser damage with only a small island of central retina that's spared. With the advent of the anti-VEGF era, treatment is now primarily driven by imaging, OCT and fluorescein angiography, and therapies are pharmacologic, modulating the ocular milieu rather than destroying portions of the retina. The improved safety of this approach has shifted the threshold for treatment to earlier disease and better initial visual acuities. With better initial visual acuities, attention is also shifted from macular to more peripheral pathology in diabetic retinopathy evaluations. The DRCR is currently evaluating ultra-widefield imaging in diabetic retinopathy in their protocol AA. When laser is applied in this model algorithm, it can be selectively utilized to treat only areas devoid of retinal capillary circulation, while sparing perfused areas in an attempt to preserve peripheral and night vision and to customize treatment to individual patients. Removing the VEGF stimulus may be beneficial in treating diabetic macular edema in cases recalcitrant to focal laser, where systemic control of blood pressure and blood sugar has already been achieved. These cases will illustrate the real-world utility of ultra-widefield fluorescein angiography combined with OCT. Here the patient presents with both proliferative diabetic retinopathy and diabetic macular edema. The ultra-widefield fluorescein angiography readily highlights areas of retinal neovascularization and retinal ischemia. PRP alone may worsen macular edema in this setting, but using anti-VEGF injections may allow for resolution of the edema and spare focal laser treatment. This second case demonstrates the peripheral ischemia does not have to be symmetrical in the same eye, nor does the distribution of fibrovascular proliferation. However, one eye yields clues about the configuration of retinal neovascularization in the other. The anterior neovascularization is surrounded by thinner ischemic retina that may be more likely to result in a retinal tear from removal of fibrovascular tissue during vitrectomy. Segmentation surrounding cortical vitreous and trimming rather than plucking the tissue may be safer in this scenario. In this last case, the ultra-widefield angiogram demonstrates severe ischemia into the macula and may help temper unrealistic, lofty post-surgical patient visual expectations. The images well delineate areas of perfused from unperfused retina, as well as laser-treated versus untreated areas to guide intraoperative application. In summary, diabetic retinopathy follows a predictable pattern of progression beginning in the peripheral retina. Ischemia and non-perfusion upregulate VEGF, which drives proliferative diabetic retinopathy and diabetic macular edema. Ultra-widefield fluorescein angiography rapidly provides easily obtainable, high-quality imaging that can assist in identifying treatment-worthy disease and guide treatments for proliferative diabetic retinopathy and diabetic macular edema. Thank you.
Thank you for attending this presentation of the Heidelberg Engineering Academy. This course has been recorded and will be viewable on heidelbergengineering.com. On behalf of all of us here at Heidelberg Engineering, thank you again and have a wonderful day.